Well, first off, I want to introduce everyone to Shelly Huckabee. She is my sister. We have a 15-year separation in age, so there's a lot of wisdom that I grew up learning about Shelly. So, Shelly, can you tell us a little bit about yourself and kind of where you started on your medical journey and how and why you got to where you are now?
Absolutely. So I began as a licensed vocational nurse. I happened upon nursing school thinking that it was just a stepping stone to go back and finish my English degree. I wanted to be an English teacher when I grew up. However, halfway through nursing school, fell in love with it. And so from there, I pursued my associate degree RN and then stair-stepped to my bachelor's and then my master's, knowing that as a master's degree nurse, I wanted to become a nurse practitioner. Once I learned as an LVN actually in a clinic. I was an agency nurse working at a primary care assignment, and I was helping them get caught up on some tasks because they had been short staffed. And I saw these people walking around in lab coats. They kept calling by their first name. And I looked and I said, who are they? What do they do? And they said, oh, that's a nurse practitioner. And so I talked to her at lunch. And I'm like, well, tell me about this role. What do you do? And she's like, well, it's a master's degree. And I remember thinking, oh my gosh, I just have this hospital diploma. How will I ever get a master's degree? So needless to say, once the ball started moving, I think I knew then, but I realized that that's what I wanted to do. That was the role that I wanted. So now I have been a nurse practitioner for 17 years. I have quite a background, strong foundation in family medicine, actually with a practice that I interned with. But in addition to that, I've worked in strong in community. My very first position was actually in the community at a transitional living center for a women's and children's shelter. I worked in school-based health. I've worked in pain management. I had my
I
own.
have to stop you for a second.
Yeah.
The transitional care,
Yeah.
that seems so unique, that helping people that ultimately really need help. How was that experience?
So, and that was my first job as a brand new nurse practitioner coming straight out of school. And that was my heart. It was funny because I said, never say never. When I first when I was getting ready to graduate and you're looking at all these opportunities, I was like, I do not want to work in pediatrics. I chose family, but the clinic that I was actually hired was at a women and children's transitional living center. It was predominantly a pediatric clinic, but they were hiring me to expand the services to the adult women, obviously the parents of these children. So when I found out that I was going to be able to help these women that truly were in transition, they had been homeless because of various different reasons, but most of them because of a bad situation relationship, typically. Some of them were in a substance abuse recovery program. And these were my patients, but they lived on site at the clinic. And the great thing about that role is you really could see how even just the smallest action, even as a brand new baby nurse practitioner, something so simple as, talking them through how to take care of their child's cold virus and what to do. They were so grateful. And you realize that even that small little action made a difference. So I will say it was very rewarding.
That's so interesting because I was recently discussing the topic of kind of the podcast YouTube channel that I've created is around the lines of health, wealth, and happiness. And I realized talking to Drew, our brother, psychologist with a deep emphasis in philosophical and devil's advocacy, backing. It's like, you don't need money to be happy. You don't need health to be happy. And happiness, I don't think that's necessary to live a good life. And I was like, this is interesting. And so upon our talking, I was like, it's meaning. Meaning is the thing that makes the most impact. And meaning is the thing that connects all three of those things.
Absolutely.
And so it's interesting that you were saying they're so grateful because to them, with almost nothing, not having that family connection, living inside of this place that you're working in, they have meaning that you're giving them. Like they're like, oh, this person's helping me, so I can continue to help.
Yeah.
That's really interesting.
Absolutely. And that's what it was. We were trying to equip them with the tools they needed for their day to day. And health was only one component of that, so that we were trying to give them what they needed so they could transition to where they were standing on their own. And so you could really, I had the privilege of watching women graduate from the program. And at one point, they actually invited me in the evenings to teach a health class just over general things that most people, at least in my circle, take for granted. And they had so many questions because they were eager to learn, but you could tell their goal was they just wanted to live the best life for them and their children. And they were like hungry for whatever we could offer them to do that.
That's so cool. So where'd you go from there?
Okay, so that was my first role, and then I stumbled upon pain management, it's a whole long story for another thing, but it was a learning experience. And then school-based health. Oh no, I had my own clinic. I had my own clinic for about 6 months, and that was fascinating. I worked.
What was the one thing you learned about working at starting your own thing, doing pain management? What was like the biggest eye-opening thing that you wish you would have taken at that moment? Because I know like leaving the business and being stressed with all the exiting of it can be very stressful. Mm-hmm. But what is that one big overarching thing that you learned from that experience?
The overarching thing. The overarching thing that I learned from that experience, not from the business side, but that whole experience, was that medicine is a ministry, and medicine was my ministry. And that's what I learned from that whole experience.
Can you expand on that a little bit? That's interesting.
Yeah, absolutely.
I feel like some people might not understand what you mean by the medicine is ministry.
Absolutely. So we all have passions and gifts, and our job, no matter what your faith background is, our jobs as humans, essentially, where that joy, that happiness that you're talking about comes from, I think we find that greatest when we're helping someone else. And so for me, for my faith, it's important. Like ministry is, it can be a spiritual, but it can be a very physical, tangible thing. And that's what I learned is in ministry, I was taking these skills and the knowledge and the assets that I have and connecting with other humans. And through my medical experience, I'm not just, I kept getting this picture of a triangle where mind, body, soul. And so, yes, I'm serving the body, helping the mind, but ultimately it's the soul. And that's what the ministry was. And so I actually, when I first started the business, I had a friend who, she had a doctorate in international economics. And I was stressed out over the early challenges of the business. We took a drive to Starbucks, and I'm telling her all my stuff. And then she listens, and then she sits me down with a notepad and a pencil. And she said, I'm going to go get a chai tea and I'll come back. But I want you to take this notepad and I want you to write down. She said, you can draw a conceptual model. You can draw a picture. You can write a list. I want you to write down what all this means to you. What's your goal? What's your purpose? And so at the top of that paper, I put God. And then I put ministry. And then finally I was like, God, family, work. And under work, I put ministry. And then she came back and she said, okay, what are your assets? What do you have going for you? What are your challenges? And so I'm like, didn't know she was going to give me homework. I thought, so I'm sitting here writing it out. And finally, a few pages later, I finally write out what medicine is ministry was to me. And it had to do with what I just kind of summed up, which is basically helping serve people by helping educate them about empowering and educating them about taking care of their health and being that person who not only you come to because you have any kind of physical problem, but that listens. People really need someone to listen to them, and that's part of that ministry. One of my patients actually shared with me, so I can't claim credit. She said, Shelly, listening is spiritual hospitality. And that has stuck with me because that's a huge, important thing. So my background being a nurse before I was a nurse practitioner, because you're a nurse first and you add all the levels of medical knowledge to that, it is the core foundation of nursing principles that we are patient-centered and patient advocate. And so sitting and listening to a patient was just something at that point in life that was just innate. And so taking that next level of skill set and adding to that where, okay, I'm going to listen to you, but I'm also going to hear what's going on and assess and diagnose and come up with a treatment plan. So that's really that's really it tied everything. It was kind of tying everything together. So here's a fascinating thing from the business. It was a financial not it was a financial nightmare. I was not a success, but I learned so much. I actually became a valuable employee to my next employer because I ended up working for the private practice where I trained. And what I learned on that business side, being a business owner, employing a physician to be because of the way the state of Texas is, you have to have a doctor delegate your prescriptive authority. So I went out and sought a doctor to be my collaborative physician, and going through that whole process, I learned how to be a valuable employee to my employer who was a physician. So I brought that in, but here's what's fascinating. So fast forward, I'm in a family medicine practice, serving from all across the whole span of life, very busy practice in the community, incidentally, which I graduated from high school from. And so I'm there for about, we'll say it was about 9 months into my work there. And I am telling you, all of my roles prior had been very kind of narrowed down, like I was in school-based health or I was in that pediatric clinic. This was the first position where I had to have this exponential learning curve because you're managing everything, chronic disease, interpreting labs, like anything can walk through the door, and it would. And so I remember lots of challenges, feeling like I should already know this stuff. I've been in NP 3 years already. How do I not know this stuff? But I had a great mentor. But I'll never forget going back and finding that notepad from when I had the clinic and flipping through it and realizing, oh my goodness, I have everything I wanted in medicine as ministry in this role right here, except one thing, and that was community outreach. And that actually developed later as I developed a closer relationship with the physician who owned the practice. We developed community outreach. So,
Sorry for the technical difficulties, but I think we figured everything out. So you were on the journey of, you left the clinic that you started, the pain management clinic, and going from there.
yeah. So as I said, when I joined the private practice with the doctor who trained me, it was there was this exponential growth, and it was there that I realized that medicine, that I had all the components of ministry except for community outreach, which would come later. And incidentally, it was during this role, I was there for 8 years, that I learned, back then I learned what functional medicine was. It was actually there. And people would say serendipity. I call it a God thing. What happened was this. The nurse practitioner who I replaced, was already starting to delve into looking into things like probiotics because she had a husband who had passed from colon cancer. And so she had a lot of unanswered questions from that Western medicine she went through this traumatic experience of her husband being treated and losing him. And there was just something that more to it. And so interestingly enough, I inherited her patients in my panel. And then I worked upstairs from a compounding pharmacy, which I actually went to high school with a pharmacist, and he's brilliant. If I could tap my brain into anybody's brain, it would be his. And so they had, a lot of supplements and a lot of learning, and they would bring, there was a lab representative where they were talking about things like saliva testing and hormone imbalance. And I was like, oh, I want to learn more about this. And what you're going to find more often than not in functional medicine is if somebody ends up exploring functional medicine, especially as a practitioner, either they had a health condition that Western medicine just couldn't fix or explain personally, or someone they love, or in my case, both. But initially it was me. I didn't follow the textbook. I had a condition and I had been trying to deal with, and this hormone thing, I was like, wait a minute. And so I was like, at the time we were just skimming the surface, but in the beginning, it literally was just looking at probiotics and realizing people could have micronutrient deficiencies. And even back then I hadn't heard the word functional medicine. I heard integrative. And so every time they would come up and bring someone to speak to the practice on a lunch hour or something and would talk about, oh, this provider practices integrative medicine, my ears would perk up. I'm like, I want to hear, what's this about? And so,
Is
of
there a
course,
difference between integrative medicine, functional medicine, and holistic medicine? Is there a,
so
or to
what
kind
you'll
of,
yeah. So what you'll find, so holistic medicine, when people think holistic, they usually are talking about, when people first hear it, they're thinking herbs, which is definitely a part, herbs, acupuncture, and definitely spiritual, which holistic, to me, the way they define holistic in nursing school was really just comprehensive. So I will say functional medicine is root cause, finding the underlying why, and digging until you find it. Sometimes there isn't, but a lot of what happens in Western traditional medicine is we're not really good with finding the why. We call symptoms diagnoses. Functional medicine is looking at micronutrient deficiencies, environmental exposures, food sensitivities, hormone imbalances, the why. Integrative is taking that traditional Western medicine and what you learn from functional medicine and combining it together. And holistic, I feel, is taking that and going even further, where you're looking at, we do have to have a good mindset. You do have to have wellness. Gratitude is important. We are what we think. So one of the most important lessons, besides learning how to manage this complex disease processes in patients in Western, even just the traditional Western medicine set in chronic disease and family practice, that I learned at this practice that I was at, was actually about my own negative self-talk. So I'm firstborn, type A in a lot of ways. I'm a perfectionist, and if school didn't cost money, I would still go. So I liked making A's. I liked getting good feedback from my professors. And if I didn't know how to do something, I would beat myself up. And I was the kind of person, I'd give a speech and I'd sit down, and the first thing I started doing was going through the speech and think of all the things I could have done differently. So imagine I'm working family medicine. There's a lot to learn, and I would go to the doctor and I'd ask him a question, and then I would be mad at myself for not knowing the answer. And I'd go, oh, I'm such a dork, or I'm so stupid. And because I'm an auditory processor, I verbally speak out what I'm thinking. He heard me. I mean, everyone around me heard me say, I'm such a dork, or what? I'm so dumb. And finally, this same doctor who taught me so much, he said, hey, quit being mean to Shelly. I like Shelly. And what happened was he called attention to my action every time I would say something negative. And it took me, I didn't even realize I was doing it. That's what's crazy. It wasn't a mindful, it was just a knee-jerk reaction. And so he did it enough to where I had to go, wait a minute. And so I would stop and think. And it really was, I had no idea how much that negative self-talk really was impacting my overall function as a clinician, as a mother, as a wife, as just a day-to-day person in society. And that was probably one of the most beneficial things that happened. And interestingly enough, I had a colleague who started as a student in our practice, and she came along, and we have similar personalities, and she followed the same suit. And I saw her doing the old things that I did, and it didn't really click in my head until I watched her go through it. And I went, oh, that's what I was saying to myself. That's what I was doing. I had no idea. So I feel holistic, that's just one little component, is really getting into mindset, thinking, whether it be prayer or meditation, but our minds and what we think and what we do with our bodies is so much. So I think that takes that integrative medicine and takes it to a whole nother level.
it's so interesting because that's the issue with just everything in life, the vocabulary part, right? Like the holistic version that I'm looking at for helping people in that personal training world, helping the individual, versus functional in my world is holistic. As I'm looking at the whole body, I'm seeing what blood panels look like. I'm looking at how they're moving, the mental state, like are they like is it negative self-talk? Is it trait anxiety? Is it somatic anxiety? Like what's going on there, to how they're moving. And then functional for me is, can the person functionally do movements? So it's so interesting that I find like there's so many ways, and I feel like that's why our world is kind of chaotic a lot of the times, because I'm saying functional the way I'm interpreting functional based on how I live my life. So I have to ask you what functional is from functional medicine, because that's something different, but it's like the same word, but it has 20, 30 different meanings depending on who you ask.
Absolutely. It's fascinating. We see that even there. It's important. If you look at papers and studies, research, oftentimes, if you realize, they'll start out identifying, okay, when we use this word, this is the context we're using it. They'll actually define those words. And I'm like, oh, why are they doing that? So, when they refer to that word in the paper or the research, that's what they're referring to. There's been so many arguments or discussions or debates that I've been in my life where it really came down to semantics, where I might have been saying the same thing the other person was, but we're just talking around each other because we're calling things different. So you're absolutely right. English, I think, especially as we move forward, I feel like English is an amazing language. We have so many words, but we kind of simplify and dumb it down. For instance, look at, and I think of our brother Drew, who's a psychologist, it makes me think of that. Love. I love pizza. I love my daughter. I love God, agape, phileo, and eros. I mean, if you love, there's different levels of love, different types of love. And so, but in English, we say love. So it is important that we define everything in context, as you've said, even when it comes to a word such as functional. And I'll be honest with you, even in the world of medicine, when they first started talking about it, they would say integrative or they would say holistic. And so finally, now they're actually accrediting bodies where they're defining, this is what we mean by functional medicine. This is what we mean by integrative. There was no one who came along and finally a collective group got together, had an accrediting body, evidence, and said, here's what we mean and let's define it.
Yeah, go ahead.
Oh, no, I was going to say, and it'll be interesting because obviously the disciplines, across different disciplines, but eventually what we're hoping to is maybe we can get to a point where we're all using the same thing across the different disciplines.
Yeah, that's what I've noticed whenever I try to do some search terms on, say, YouTube or podcasts to see what people are talking about. And a lot of the integrated physicians, they're very articulate with how they'll word certain things. They don't want to say they're holistic. They don't want to say anything about helping someone other than with medication. And so I find it interesting because it's like, well, you have a lot of these deep values based in helping people, but you don't want to use your words to say that you're helping people. So I find that interesting. It's like, I want to be a physician, but I don't want to be a holistic physician, but I'll say I'm a integrated medicine physician, but I'm not going to talk about the holistic side of things. So it does seem like there's like that dichotomy of what people are and what they want to be associated with on both sides.
Absolutely. And it all goes down to connotations, actually. And so what happens is, for a long time, if you said holistic or you say functional, if you go Google it right now and look in Wikipedia, if you look up functional medicine, it will say it is a type of quackery that is not founded on science.
Functional medicine? Is that what you said?
Yeah. Look up functional medicine and it's fascinating. Even though we know, I mean, some of our, functional medicine giants, there's A4M, there's IFM, there's Dr. Hyman, among many others. We know that there's research and there's evidence and there's so much support. But if you look it up in Wikipedia,
functional medicine is a form of alternative medicine that encompasses a number of unproven and disproven methods and treatments. That's the first line. And it just, it's basically saying that it's not accredited and it's pseudoscience quackery.
Yep. And when I saw, how you can edit Wikipedia. Yep. I read that a few times and I was so frustrated. So one time I actually went in there and went, wait a minute, we have just as much evidence as, and I never have done that, but I was like, wait a minute, we do have. It's fascinating. So the reason why they're so cautious is because once you put yourself out there like that, there's this connotation. And so unfortunately, there has to be some of us who are going to be trailblazers and to pave the path so that people realize and to educate. I'll never forget when I first started talking to even some of my colleagues in family medicine about the reality of gluten sensitivity that was non-celiac, or about the fact that there was so much vitamin D deficiency and there was an issue. And when even one of my very well-respected, amazing colleagues thought it was just a fad and it was crazy. She thought it was kind of crazy. And so I was so excited when I went to a nurse practitioner conference, and one of the gurus of nursing practice, she's actually a doctorate of nursing practice, one of her conferences was over vitamin D deficiency. And I'm like, yes, okay, I'm not because for a while I felt like the crazy person out in a silo and I'm saying things, but there's a physician that I know and respect who he was ahead of the game. He brilliant studying, reading, and was very well versed. And I went to him in distress because as you're learning and you're realizing there's a lot more to the picture than just what we were taught in Western medicine. In the beginning, you feel a little shell shock and you might kind of feel like, have I been studying a lie? What is this all about? So I remember going to him and saying, hey, I feel like everything I learned, it's just crazy. I feel like I've been taught this big lie and there's so much more to this that I didn't know. And he said, here's the thing, Shelly. First of all, if you're ahead of the curve, people are going to think you're crazy. So don't take it personal and don't stop seeking knowledge. He said, they'll catch up. And he said, two, you're always going to have, they always used to say there's like three people. You're always going to have the people in life who you can tell them everything you can about lifestyle and nutrition and all of these things. And they're going to go, I hear ya. I, for whatever reason, I'm not going to make the change. Just give me the pill. And then you're going to have people who are like, I don't want a prescription drug. Please tell me all the things I need to do. And then there's the people who haven't figured out, that they have options.
Yeah, that's really interesting in the aspect, because whenever we look at, for example, holistic and on my side of the table, right?
Mm-hmm.
I'm thinking about people, talking to them in such a way that if I say I'm a holistic health coach, they look at me like I'm going to give them herbs and hypnosis, etc. And I don't know enough about that, right?
Mm-hmm.
I've gone back and forth with the different terminologies. I've gone back and forth with the different ways of thinking, okay, this does apply, this doesn't apply. Okay, now new information comes out, it does apply. So it's almost like you're stuck in these boxes where if I want to have a conversation with someone about a scientific topic, I have to know that topic and I have to understand the science there. The issue that I've come across multiple times, which is, it's irritating to me, but it's also a growing path for me, is I think something may be possible. I think there's information that we don't know yet, such as I think doing full squats or putting your knees over your toes, I think all of that stuff is fine. If you read any textbook about biomechanics, it says don't do that because it puts strain on your knee. So, well, why is it every time I'm helping people and I'm getting their knees over their toes, they're performing better, they're doing better? It's supposed to be bad for you, but you're doing better. And if you talk to someone who's deep into the science of biomechanics and exercise physiologist, and you're talking to them about any nutritional thing, they're going to say, follow my fitness, or what is it called? What's the government? My fitness plate, or my plate, I think.
Yeah, my fitness pal or whatever.
Yeah, myplate.gov.
My plate.
So,
okay, gotcha. Oh, yes.
Yeah, so it's like, okay, we're no longer doing the food pyramid. Now we have a plate. It's like, yeah, for most people, if you take a bell curve and people eat that diet and they stick to the calories that it says they're supposed to stick to, are they going to die? No. Are they going to live a ultimately healthy life? I would assume not. They're going to, the average person will live the average life with that information.
Absolutely.
So then it's like, okay, well, now I learn a little bit, like you said, with gluten. I learned a little bit about gluten. I took gluten out of my diet for 30 days. And then that person eats gluten again. They're like, oh, my stomach, it's like, it's bubbly. I'm more gassy. Maybe there is something to this. And then it goes down that long rabbit hole.
Mm-hmm.
But I do think there is an issue with the very intelligent people that we need to do science, them saying, no, there's no information on that. So it's a hard no. It's like, well, why don't we say, instead of no, because you're a scientist, let's say that it's data, we can't accept new data yet because there's not data on that.
Yeah.
Until there's data on that, then we can accept it. But anything's possible in the future. We just can't say we accept that information based on the data we have currently.
Absolutely. And that's what science is supposed to be. Science is about testing the limits and trying to replicate. And unfortunately, we live in an age right now where science has, not everyone, but there are a certain group, a subgroup of society that has made science something beyond that. Trust the science. I am the science, all of these things. No, science is a process. It's not a person. It's not a faith. It's become a faith for some people, but it's really, truly not. It's a process. And if you can't take that scientific process and ask those questions and go, hey, I know we always taught this, but my thought is this, let's test that hypothesis that if I take these, I don't know your field, but I take and I put the knees over the toes and let's get some data and see what happens with this person. That's what science is about. And circling back a little bit about what you said earlier about yes, we finally, it took us how many years to realize the food guide pyramid was obsolete because we're not farmers working in the field anymore. And even the plate, we know that's ideal. It reminds me of labs. Even when you look at labs for hormones or thyroid or vitamin levels and such, there's what's called normal range. And I've had several people go, well, it says my vitamin D is in normal. What is it? It's 35. Okay, I know according to that lab value, it says normal, but optimal is 60 to 100. So you're right, the average life, but that's not necessarily the optimal life. You can eat that plate.gov and have the average life, but do you want average or do you want optimal? And it's up to you to decide. It's your personal liberty. I do want to share one other quote with you that's on the means of what we're talking about in the same line, the same vein. And it was actually fascinating to me. It was actually a quote by Alvin Toffler, and it says, the illiterate of the 21st century will not be those who cannot read and write, but those who cannot learn, unlearn, and relearn.
Ooh, I like that.
Yeah. And that's what it is.
Who was that again?
His name is Alvin Toffler, Toffler. So we're in a world where we're in left, right, whatever it is, any discussion, not even politics, just here's where I stand on this and here's where you stand on that. And we're just
a spectrum.
And I only want to hear people who tell me, and you only want to hear people tell you, but we don't get anywhere. We don't move forward as a society when we function that way, whether it be about medicine or anything. I have to be willing to go, here's what I've always learned. And I've had all these amazing people pour into me. I've had all this experience, but what you just said, that's interesting. That may or may not be true. Let me set my own thoughts about that aside and let's explore what you have and what your experience is and see where the common ground is, because we'll only move forward when we're able to go, what if the way we always did it wasn't, maybe it was the best at the time, but we have new information. We have new knowledge. We know things about mitochondria now, besides the fact that it's just the powerhouse of the body. Yes, I knew that in 7th grade. I knew that in 10th grade. Now we know that there's so much more to mitochondria in the body. We had no idea. And I remember when I was at this family practice, it was probably about 10 years ago when they were just starting to talk about mitochondrial support and how that was important. And it was just, not even 10 years, it was probably about 8 years ago. And I remember going, hey, I gotta look into this and going over to the physical therapist who said, yeah, we're going to use some infrared laser. My husband had basically torn a ligament in his ankle and it was bruised, and we didn't have health insurance at the time. So we go over to the physical therapist and they take a look and they do the mitochondria. 2 days later, his ankle looks amazing. And I'm like, what was that light? What was that about? I remember you telling me, but tell me more. And he said, that red light stimulates the mitochondria of the cell to respond. And I'm like, tell me more, because I watched before my eyes this healing that if he would have told me that from the beginning, I would have been like, okay, yeah, maybe whatever. I knew the guy and I trust him, but I would have been like, okay, that sounds kind of weird. A red light. We know way more about it now, but you know what I mean? Back then.
That's the whole field of photobiomodulation, right? Like you take infrared light, you take a red light at 660 wavelength, and you shine that on your body, and just like that normal 660 wavelength, people are showing less redness in the face, or less inflammation in the body. Then you have the more penetrative light, the infrared light, which you can't see to the human eye, but it's going a little bit deeper, and then it's fixing problems like inflammation of joints. And it seems whenever you first tell someone that, they're like, that doesn't make sense. It's like, well, go Google, type in google.scholar and type in photobiomodulation or red light therapy or light therapy or laser therapy, and you're going to get all kinds of studies that you can just start trickling through. And it's so fascinating.
It is. It is. And that's where we have to, no matter what our discipline is, we have to be, one of my nursing instructors, again, I've had some amazing mentors in my life, Cindy Peterson. She was my associate degree RN nursing instructor, one of many. She said, as long as you're green, you will grow. If you're ripe, you'll rot. We have to be willing to be green. We have to be willing to say, I know a lot, but I have so much more to learn, no matter where you are.
Yeah. It's the Dunning-Kruger effect, which is a
Yes.
timeline of you have confidence on one side, and then across the confidence is on the y-axis and the time is across the x-axis. So as you start off, like say, a lot of people can experience this if you talk to someone who just got out of college. Someone who just got out of college is very confident in their ability, but they don't know a lot, but they'll act like they know so much. Then give them 2 or 3 years in the workforce, and then this confidence level goes down because they're like, oh, I don't know that much. I'm starting to realize. So you start noticing by the time people are 5-10 years out of their educational path or starting a new, I read this article, so I know a lot about it, and they learn more about it. 10 years later, they're very, I don't know. Like, I need to learn more. I can't answer these questions. So then you start going from, how do I lose weight, eat less calories? You have that mindset to, how do I lose weight? It depends. How are we going to lose the weight? What are all the other thousands of variables in life? Like, is it your metabolism is so low that your body only needs 1,000 calories per day to strive? And if you're eating 1,500 calories, which based on your body weight should be the appropriate amount of calories, then you cut back to 1,000. Well, now you're at what your body's needing, so you're not going to lose or gain weight. But that's not taken into account because you have that first person who says, weight loss is simple. Weight loss is just this. And it is, but there's
Depending,
more. There's always
depending
the
on
but.
circumstances. Absolutely. We, as I think our human nature is, we want simple fixes. We want simple box. We want a checklist that we can just do, whether it be nutrition, health, relationships. The reality is, if you're in any kind of relationship, it takes work. It evolves. It depends on the day. You have two, organisms that are dealing with all their different variables, and it's the same thing with health, and it's the same thing with because our health, we are mind, body, soul. There's so many variables now. That can be overwhelming. That can seem like, but one of the doctors that trained me, he said, there can be lots of like layers of an onion, lots of things going on. But sometimes if you just kind of if you can define and tweak a few of those, you can get things moving in the right direction. And you have to look, are we moving forward from where we were? And that's what we always have to look at. Are we moving forward? And our world's constantly changing. So we're going to change in our world. Things are changing. So we have to be open to changing, and even in our thought process. So I'm not sure why we can't say, oh, we got to be learning more, because we're in a constant state of change.
I think sometimes it's because we're changing so much. I think a lot of I'm guilty of this. I'm learning so much stuff that something new happens outside of the stuff I'm learning, or that I'm this mental stimulus that's going on, that I'm like, I don't say it, but I mentally, like, I can't take in any more information on that thing.
Yeah.
So I can't learn that thing. And I've done that many times, but I'm also the type of person, I want to learn everything. I want to learn about astrology. I want to learn about, I love health, business, the psychology. I love all those aspects. But then there are certain things like you brought up politics earlier. That's one of the things I try to get into, but then I get into that and it's like, okay, now that's taking up bandwidth of the stuff that I love to do.
Yeah.
And then if we get in like wood making, I love building stuff with wood, but I can't do that because I'm doing, so it's, I think our time is precious to us.
Mm-hmm.
And then at the same time, we don't realize that it's precious to us because we say, oh, this is simple. Let's just do that thing because that's what I
Yeah.
read last. So
Yeah, and you know, you have to find some place where you can negotiate and work, because otherwise we can't, you know, we'll be in a state of flux. So one, we have to accept our limitations as humans, which means we are limited by time. We are limited by how much we can absorb, or how much, I mean, we've all got to get sleep. We've got to have, but so what I always tell my patients, when I was learning all of this stuff, I got overwhelmed, and I still have so much more to learn. But in just the beginning, when I was just scratching the surface, and I would share it with my patients in family medicine. You have this person who came in, they know they're overweight. They realize maybe my blood pressure, I mean, I'm just not feeling right. I'm getting headaches. I've gained weight. Something's off. And they come into your office and you tell them, okay, you have high blood pressure, you have diabetes. I need you to change this, and this, and this. And they'd walk out of there and they'll probably not come see you again until they're feeling bad. So I would always tell them, look, there's a lot of things we're going to have to work on. It's overwhelming if I tell you all of them, but we know that here are the categories, and here let me give you three simple things to work on, and then we're going to come back and we're going to revisit and see how you do, because I've learned if it's too much at once, they're going to get overwhelmed and they're going to quit. And sometimes actually you also have to gauge that by the person. Some people can't do three, some people can do one, and you have a conversation and you get feedback, and that's even staying away from that. There's a whole readiness for change and all of that. But typically when people are facing a diagnosis, they realize something has to give, whether they want it to or not. And so go ahead.
Where did you find three? Because I found the same thing whenever I work with clients for movement stuff. Three is about that maximum number. So how did you find that?
I just honestly years of experience, and that's what I realized, that's about what they held on to. Because I won't say that brand new, eager, excited nurse practitioner who wanted to save the world. I mean, I've sent people out with these lists of everything, and then I realized when they came back that it was overwhelming them, and I had to just stop and think. And I realized, you know, we can all, like, for instance, when we do a mini mental exam for the cognitive function, we'll tell them 3 words and have them recall those 3 words later. So maybe there's something in that 3. Like, I should be able to remember 3 things. Like 3 is simple. Like 1, 2, 3, 1, 2, 3. And it just seems like a simple place to start. So how I came to that was honestly just trial and error through years of taking care of people and realizing, one, I was overwhelming. But I needed to assign them something to do, and they had so much going on with their body. So I knew we had to at least start somewhere. And so 3 seemed to be like that sweet spot for most people.
That's what I noticed whenever I first trained the first person. It's like, we're going to do these 10 things with your diet. We're going to do these 10 different movements that are complex. And then you have to learn everything about those 10 movements, and they're like, I can't work with you. Like this, it's too much. I was like, oh, okay. And I'd work with someone else and do the same thing. And they're like, okay. I'm like, oh, are you doing this? Well, no. And then finally, after years of experience, it's like, let's see what makes the most difference. You know, you could have someone that just does all the unhealthy thing. And I made a post the other day that said, weight loss is simple. And this is for like the average person, because most people just innately know what's healthy and what's not healthy. If you tell anyone to eat the difference between 2 diets, if you eat donuts in the morning, fast food in the evening, fast food at night, versus food you cook at home for breakfast, normal breakfast foods, whatever you think about as breakfast foods, food you cook in the afternoon, normal just afternoon foods that you can cook at home, or dinner foods that you're cooking, most people would say that the foods you're cooking at home are probably going to be healthier. They don't know what you're cooking.
Mm-hmm.
You just said you're cooking stuff at home, but they know that that's probably going to be healthier than fast food. So I do think that there's that like difference of people know to a certain point, right? Then you get to the next stage of, I'm trying all these things. What do I do next? And they come to someone like me or you, and they're like, oh, I'm eating, I'm drinking Diet Cokes. I'm eating a low calorie. I'm supposed to, we look at their body weight and we're like, okay, they're supposed to have around 1,800 calories a day. They've been eating 1,000 calories for the past 10 years. they're drinking all the Diet Cokes, they're eating maybe low fat. Then you're like, let's start adding fat to your diet so your hormones can function properly. Let's get you off of Diet Coke, because I mean, there's a lot of controversy over Diet Coke and the sugars and the fake sugars. My whole
Still
thing
causes
is,
it causes insulin release,
yeah, my whole
even
thing
though,
is, if you just look at the basics of drinking something that tastes sweet, then you're always craving something sweet. And it's
mhm,
so sweet that, to me, it's just making you want something more sweet, so later on down the road. And there's a lot of bodybuilders that use it, and they do fine with it based on the information we have, right? So it is really interesting whenever we take someone from I'm doing things simple to I'm doing
mhm.
things and I can't figure out how to go forward.
Yeah,
That's where a lot of people don't realize that, though. They don't know where to
yeah,
go. They've tried all the things, right? You talk to these
yeah.
people and I've tried everything and it's not working. Well, maybe not.
And, yeah, and that's where clinicians, practitioners, uh, come in, because what happens is, um, we have dedicated our lives to studying, especially the physiology of mind, body, soul, but especially this part of the body. And so where they're doing things that I can't, like I can't repair my AC or my car, and thank God there's people who have spent and dedicated their time and energy or natural affinity for that. So I'm going to take my car to them because I don't know that. But this
Yeah.
is where I've spent my time becoming an expert, and still learning though. And so, uh, we have to, it's what you said, we have to kind of start where they are. We got to meet them where they are and go, what do you, where, that's where our assessment comes in. Where are you? What are you doing? Okay, let's tweak and then gradually build. And I think that's what I had to learn over time as a clinician, because I was, again, wanting to save the world. Let's do all the things. Well, then they, like you, they'd come back and go, Shelly, I can't do all the things. Okay. Then I'd go, okay, can you do one thing for me? And they go, yeah, I can do one thing. What is it? And so we'd start with one thing. I'll never forget. I had a lady come back to me, and she had been struggling, and she had lost about 20 pounds, and her blood pressure came down 10 points, and her labs were great. And I said, hey, what did you do? She goes, you told me to start walking, so I did. And she goes, that's the only thing I changed. And I'm like, she goes, and I did it every day. And I was like, one thing, because I think sometimes too, as clinicians, we also see the big picture of all these different numbers, and we see all the things wrong and we want to fix. So it's even very humbling for us to go, they have limitations. We have to meet them where they are. And it's either I overwhelm them with 10 things, as you and I both have learned, or I can get them to do one thing really well and then add to that. And that's what I had to learn over time, because in the beginning, you're just so ambitious and you want to fix everybody and save everybody. And I didn't, it's kind of like the old adage, how do you eat an elephant one bite at a time? Why would you want to eat an elephant? But anyway, it's the same thing. You have to take it one bite at a time, because otherwise we're going to lose them. They're going to lose confidence in themselves and in us. And so it's an experience thing. But what we said, I think the key, the take home in all of this conversation is, the most important is, where are you now and how can I, with my knowledge in my field, help you get where you are to move forward?
Yeah, definitely. I think going into the holistic side, I think that helps you process those things more. Do you think that's the same as with true for your end going into,
Absolutely.
or is that
Absolutely.
just learning and experience?
Well, learning and experience, but also having a holistic approach, because you realize you're taking care. If I could go in and focus, and I've seen this happen, I could just focus on somebody's hemoglobin A1C, which is the 3-month mark that we measure for somebody's diabetes control. It's an average, it's an index, and it gives me a number to let me estimate how their 3 months of blood sugar was. My father, he was diabetic, and his doctor was so fixated on his A1C. There's a couple of reasons. One, that's how they trained us. Two, insurance companies now are reimbursing on your performance. And if you have so many patients that don't have their A1C at goal, then guess what? You get dinged on how much you're reimbursed. So that's a whole nother story we won't get into. But anyway, this doctor was so fixated on my dad's A1C. And I wanted dad's A1C down too. But if you looked at my dad's individual blood sugars, what was happening is he was plummeting. And if you know anything about diabetes, yeah, we don't want you high up in the 300s so you don't end up on dialysis with kidney issues but if you get down in the 40s, you can die. And what was happening is the doctor was so fixated on driving that number down that he kept upping my dad's insulin. And my dad kept having low blood sugar incidents to where he was passing out. And unfortunately, he was widowed and living alone at home. And it was dangerous. It was scary. And I finally had to change physicians and tell them, explain to them, he's super sensitive to any insulin changes you give him. You're going to have to do it gradual. So it would be too easy to just get fixated on a blood pressure or a number or a cholesterol. And unfortunately, sadly, in Western medicine, we're seeing high volumes of patients. You're seeing, you've got the schedule, and a lot of the private practices now have been bought up by hospital systems and such. There's a lot of different variables, but what happens is you've got these people with all these things. And so you're looking at the numbers, but you can't just look at numbers. You have to look at the person. You have to see what they're able to do, because like that doctor with my dad, all he cared about was getting that number down. And unfortunately, he didn't take time to listen to my dad. I said, Dad, did you tell the doctor when he goes up by 5 units, you crash? He goes, Shelly, I tried to tell him. And so finally, I just had to get another doctor who didn't have tunnel vision on a number. And so thinking holistically, thinking outside the box, not getting that tunnel vision about pillet problem, measure, number. The labs are important. Data is important. But again, amazing nursing instructor. One of my first nursing instructors, Barbara Bohannon, God rest her soul, she would quiz us as we were LVN students. And she'd say, okay, I'm going to give you a patient scenario. You're working on your telemetry unit and you see asystole and you go into the patient's room. What is the first thing you do? And of course, all of us knew not, grab the crash cart, blah, blah, blah. Check the patient. Maybe the patient took off their monitor, check the patient. So you have to be able to, yes, look at this data, but let's talk to the patient. Let's talk about how you're feeling. Let's talk about your life. If I give you this, like say you give somebody a movement that you want them to do and they don't do it. And you're like, well, if you just said, well, I want to do this movement, but if you go, hey, you couldn't, why couldn't you? And there might be some obstacle or some barrier that you didn't identify just because you didn't go, why aren't you moving it? And I will tell you the why. I've always been kind of a why kid, but really getting into functional medicine, holistic approach is why. So you have to look at why in all things.
I kind of want to share something.
Okay.
So, because you brought up the glucose thing, and recently I wore my first, and I was messaging you and one of my other friends who is a type 1 diabetic. Basically, I sent you some of my values before, and it just stayed. Fasting was around 100, and then I would eat something, and then I would check 30 minutes later, 40 minutes later, an hour later, and it's back down to 100. And so by day 2, my wife, Lindsay, would wake up. She's like, what's your blood glucose? I was like, what do you think? It's probably going to be 100. And I look at it, I was like, yeah, 102, 99. It always stayed around that 100 mark. And I find it so interesting because I started testing towards the end to see if I can get like real high blood sugar spikes. And then I tried going into ketosis to see like what would happen with my body. And it always stayed like on a normal day, eating cassava flour, which I thought was healthy for me, I thought would be more beneficial for me, that jumped my blood glucose. And it's probably still healthier than because my pancreas and everything's working.
Yeah.
But that was the highest spike I saw, where it jumped up to, I think, like 165. And then it went back down quickly, but I could have pancakes in the morning with syrup on it. I could have ice cream and I could have other things and it would jump up to 150. But can you explain to people that like the glucose thing, showing the difference between how my blood glucose would jump up a little bit because it's supposed to, and then it would come down a little bit lower than where it was, and then back up, how that metabolic flexibility that it seems like I was showing is different from someone who stays up, and it stays up at whatever number that's like unhealthy, which you would know those numbers, and stay elevated for a long time, or go through ups And then
Ups and
insulin gets
downs. Yep.
released, and then downs and ups and downs. Could you explain some of that a little bit more?
Absolutely. And that's exactly when you showed me that screen, I was actually excited and jealous. And that's the goal for everyone actually, is that metabolic flexibility. We should be able to, and the reason you have such metabolic flexibility is because you are doing all of these fitness things. So your metabolic flexibility is because of all the underlying legwork that you're doing allows you to have those moments to where it's going to go up, but it's going to come back down. And that was something you achieve over time. But what happens in insulin resistance, and unfortunately, we see it more and more. Metabolic syndrome is typically you see elevated triglycerides. You're starting to see insulin resistance. You're going to start seeing central obesity, where they're gaining weight around the belly, fatigue. And so what happens, unfortunately, because of the standard American diet, and the way our bodies were designed to be and what we're actually eating, we've worn out our pancreas. What happens typically, so we eat something sweet, our body releases insulin. Okay, so it's the insulin's going to go to bring the blood sugar down, get the blood in the cells. But what happens is the insulin stays in the system longer. And so then we're going to need to eat again. And that's what happens, is you end up on this cycle. But you have some people that they've worn their pancreas out. It's kind of like turning on the air conditioner that's sputtering out, and you keep turning and running it until it goes undone and it doesn't cool the house off anymore. And so the pancreas, you become no longer insulin sensitive. And so you need that insulin, as they always taught us in school. It's the kind of the key that unlocks to help the glucose move across the cell. Well, there's so much more than they taught us initially in school that we didn't realize. The kind of sugar matters. I mean, the liver, gluconeogenesis, so many of these things have an impact on what our liver's doing and what our body. And so what happens is you're having, like you said, roller coaster rides, or we have people that once they become type 2 diabetic, they get high and they stay high unless they give insulin. And here's the challenge. So they start out on a lot of oral medications, that for metformin is the first line drug. And so it helps the liver, it keeps the liver from storing more glucose. And then they end up on one of the old drugs that's cheap and cost effective, is sulfonylureas, which actually lower blood sugar, but then you got to be careful because you get too low. And then they're definitely, if you're just on a sulfonylurea, you're doing the roller coaster. Well, then you get people on insulin. And interestingly enough, and now I don't have enough, it's fast. This is just So the insulin we used to prescribe to people and what we give now is different. Now we're giving Humalogs and Novalogs, and we used to give just like regular insulin, which is really cheap. But fascinatingly, and I always wonder, I'm like,
Is it insulin synthesized insulin, or is it like
yeah,
what kind of
yeah.
insulin is it?
So
Synthesized?
it's synthetic, and so that's what's fascinating. You got human insulin, pig insulin, and now you have the synthetic insulin. So I'm one of those people. If you give me a synthetic hormone, my body does not like it, and it's likely because I have genetic predisposition to autoimmune, and my body just doesn't like synthetic stuff. That's why I can't take Synthroid. I take a compound bioidentical thyroid medicine for my hyperthyroidism. So it makes me go, when we have all this synthetic insulin, and we used to give like human insulin and pig insulin, but fascinatingly enough, we know no matter what insulin, the more you give somebody insulin, the more they're going to store fat. So the more weight they're going to gain. So then they end up in this vicious cycle. And that's why typically, my dad was an exception. Typically diabetics are heavy. He was a skinny diabetic. I think his diabetes was I won't get into that, but his wasn't a very typical diabetes. But yeah, they end up putting on weight because the more, and you'll see that if you have to keep driving up their insulin, whether it be basal insulin. Now, basal insulin is something we give to them that supposed to have a 24-hour steady, like our body's also always releasing a steady amount of insulin. And so we're trying to mimic that with a prescription drug. There's some medicines like that, the basal insulin. But even if you start to increase their insulin, whether it be basal or fast acting, over time, the higher insulin, and the patients will tell you, I'm more hungry. I want to eat more. Well, yeah. I mean, and then they put more weight on. So
Because if you're dumping insulin into the body, the next thing that happens is ghrelin comes through, right?
mm-hmm. Yeah.
Which ghrelin
And
is the hormone that makes you hungry.
Exactly. And guess what? They never taught us about ghrelin. They never taught us about leptin. We learned all of the, we were learning, sulfonylureas and biguanides, and we were learning about GLP-1s, but we never learned about ghrelin or leptin or some of the basic things that have a huge impact on insulin resistance, gluconeogenesis, and the whole process. I didn't learn any of that until I started studying functional medicine. So it's really fascinating going, oh, gosh, that makes sense. I used to think I was just bad human because in my own personal struggle with hormone imbalance and with weight, I just thought and I'm one of those, I will do, you tell me I can't do something, I will find a way to do it because I have a very strong will. And so when I would struggle with my weight and I was doing all the things and it wasn't working, I'm like, I'm just bad human. Or I was finally, when John Hopkins released that study, finally going, hey, you can take somebody who's metabolically sound and you get them to smell a cheeseburger and their dopamine is going to be small and then they eat it and it gets big. But you take someone who's unmetabolically sound, they're messed up in whatever reason, they smell the cheeseburger, their dopamine's this big and they eat it and it actually shrinks. So they need 2 cheeseburgers. And I remember seeing that actually, surprisingly, on the news. And I remember thinking, oh my gosh, I'm not bad human. There is something physiologically going on in my body that's causing this. And it was just a relief because I thought I was just a bad human that had no self-control.
That's crazy. So you said if you keep giving yourself insulin, that leads me to the question of, like, if our pancreas is always working and we're relatively healthy, we're not pre-diabetic yet, could something like fasting or resisting food be beneficial for giving the pancreas rest and a break?
Absolutely. Intermittent fasting, there's more and more data all the time. Intermittent fasting helps insulin sensitivity. Yes. Nobody likes to
Interesting.
fast. And you can't take somebody who's, even say they're pre-diabetic, they're not even diabetic. If you take somebody who's pre-diabetic eating a standard American diet, you can't take them straight to intermittent fasting, obviously, but you can graduate them down. You start them with an hour and you build them up little by little. But intermittent fasting, and there are so many books, and I'm a consumer of that information right now. I'm still considering myself a little bit above a novice, but there is so much data out there about intermittent fasting helping insulin sensitivity. And I've actually personally experienced that. And I've actually watched my husband. My husband started intermittent fasting and changed his diet in just 1 month, 5 weeks. 5 weeks, his A1C, which was at a 6.3, which is that borderline. They say, well, there's no pre-diabetes. It's insulin resistant. It's pre-diabetic. His A1C in 5 weeks went down to 5.6.
Interesting.
Yeah.
Yeah, I thought about that because what was I using the other day? Oh, I was using like the food processor. And if you hold the food processor down for a long time, it starts like getting hot and you can smell like the plastic starting to burn in it. It's like, oh, okay, well, let it go. And whenever you said like the AC is going out and you keep trying to start it and keep running it, it's like, well, just let it cool down for a little bit and then it'll work. So thinking about that, I feel like there's so much benefit. It's hard in the fitness world because a lot of the new science that we were talking about earlier, that like it's not science yet, but bodybuilders are doing it. So it's like kind of like what a lot of people call Broscience. It's we're pushing the boundaries so far because you aren't catching up to us yet. So a lot of that Broscience was, I need to eat every 2 to 3 hours. So I need my protein shake, waking up in the middle of the night. A lot of people don't realize almost everyone does intermittent fasting and they don't realize it. They're like, how? Are you sleeping at nighttime? Well,
Are
that's
you
8
waking up
hours
to
of
eat?
fasting. Yeah, that's 8 hours of fasting. So, and I've had so many clients come to me, like, we're doing nutrition stuff. And they're like, the only thing I can say that I want to tell you right away is I hate eating breakfast. That's the hardest part. And I know I'm going to have to eat breakfast. I'm like, no, you don't. And they just get blown away because they're like, what do you mean I don't have to eat breakfast? I'm like, if you don't like eating breakfast, there's no need to have breakfast. And you can just see people just get so excited because they're like, I've never liked it, but I've been forced to eat it. And everyone told me I need to have my 3 to 4 meals a day and all the snacks. I'm like, why? Why are they saying that? And most people don't ask why enough.
No, they don't. And there are some people that whatever they're doing or their physiology, maybe they need that, but there are people who aren't. And fasting is actually a huge tool. And I naturally just wasn't a breakfast eater, but I would force myself to eat breakfast because I was told, I was told it's the most important. You got to kickstart your metabolism. If you don't eat breakfast, your metabolism is going to suffer. I, as I was learning more about intermittent fasting, I just naturally was like, okay, I'm just going to kind of intuitively go with my body and I'm going to not eat until I feel hungry. And I wouldn't get hungry until about noon, sometimes not till 2 o'clock. And I will tell you, and I'm drinking water and sometimes coffee with stevia. And I would do sometimes with the butter, like the bulletproof coffee, and sometimes no, the MC2 oil or whatever, sometimes just water. But I would feel clear. You would think, oh, you're tired. No, I would feel clearer in my head. I would have more stamina. I wasn't reaching for a 4 o'clock 4 o'clock cup of coffee to get me through that little lull, because I actually waited to eat when my body was hungry. And so I learned. Now, granted, I'm not a bodybuilder. I'm not running marathons. So I think, again, we have to take what we know, what we've learned, and also fit that to what's going on with the client. But yeah, there's a lot of these things that we were taught that this is set in stone. And that's where we have to learn metabolic flexibility. We have to have flexibility even with that's the biggest thing I think I've learned, and that can sum up besides root cause with functional medicine, is there is no one size fits all medicine. There's no one size fit all training. There are principles and guides. And I tell my patients this all the time. I said, there has to be principles. There has to be guides. There has to be the textbook. Without the textbook, it's voodoo. We have to have some kind of principles and some kind of information. But like your bodybuilders, what's happening is what's in the textbook. It's like the computer. My husband he worked in computer field for a long time before he became a teacher. And he said all of his friends that were getting computer science degrees in the college, which they were learning in the college, that was old technology. There was so much cutting edge stuff that you had to stay on top of that had nothing to do with the classes they're going to. We're going to see that in every discipline. And that's why continuing education is important, et cetera. So there's always going to be pushing that limits, but we can find a place to kind of take the new stuff we've learned, let it be founded on those principles of things that have been, and build from there and then some things are, I wish we had the Star Trek thing. Some things are reasonable, intelligent. My old instructor, Pat Crotwell, used to say, she called it a swag, a scientific wild ass guess. And she'd go, you're not just going, oh, gut feeling or whatever. You're taking what you know and you're making an educated guess going, okay, let's take what we know about you. Let's take what we know about theory and things that have been proven and let's tailor it to you. And then there is a little trial and error. But let me tell you something. And you see what works and you try it and you go, okay, how do you feel? I'm sure you do that with clients. You have them do a movement and you go, how did you feel? How did that make your body feel? I'm doing physical therapy right now. The first thing they ask you after you do it, after I did a session, is how did that feel? Rate your pain when you did it, rate this. Well, interestingly enough, if somebody came into my primary care practice and they tell me, I mean, they're not having any suicidal ideation or anything severe where I need to send them off to a psychiatrist, and they're having symptoms of depression or mild anxiety, and I'm going to manage it, I tell the patients, hey, we know a place to start. I wish I could say I had the Star Trek thingy and said, oh, I know this medicine's going to work for you, but here's what we're going to try. Here's possible side effects you might have it. If you do, we'll give it a little time and see if your body adjusts. And if not, we're going to have to try another one. And our rule of thumb where I practice, just because it was just a good, safe, unspoken rule, is if after you tried a patient on 2 agents and you couldn't kind of get them where they needed to be, then we would refer to the specialist, even if it was mild. But we've learned a lot more. I've learned a lot more things since then that could help people that I didn't know back then. But that even with standard Western traditional science evidence, we tout evidence-based medicine, there's trial and error. And I always say this, medicine is an art and a science. Without the science, it would be voodoo. It's important, but it's more of an art than a science. But don't tell the doctors that.
Oh, this is all great information.
Mhm.
So to wrap this up a little bit, what is your next journey in your career? Like, where does your future look like? What does your 5-year, 10-year Shelly look like to you?
So, what I am actually actively pursuing is a certification in functional health. I want to be a certified functional health provider. The reason I'm doing that is all this functional medicine stuff that I've self studied because data, repeatable data is important. I'm learning it in a more structured format so that I can actually, in addition to take what I know, to build on that in a structured form, so that I want to become a certified functional health practitioner, so that I can treat and probably more integrative when it's all said and done. So I can take those patients who come to my office, and I'll have the person who says, I have high blood pressure. Give me my pill, give me my statin drug, send me out the door. Shelly, I'm not going to change my diet. But then I'll have the person who goes, you know what, Shelly, my blood pressure's going up. I don't want to take medicine. What can I do differently? And I'll be like, oh, let's look at some of those underlying root cause factors and help them, you know, our gut has more serotonin than our brain does. And we didn't know that until relatively recently. And so some of these people with the depression, anxiety going, okay, is this just, what's the underlying issue? So my goal as a nurse practitioner is I want to become a certified functional medicine so that I can have structured information and a structured process of taking all that information I know so that I can help patients get to the underlying why so that they don't have to live an average life. I want them to live the best optimal life for them and whatever that looks like.
That's awesome. Do you have to have a physician over you in that as well? Or
So
can you
if
do that privately?
Yeah. So in the state of Texas, the only reason you need a physician is if you're going to prescribe medication. So if I chose to be a certified functional medicine practitioner, where I can order labs, I can interpret labs, I can assess, I can diagnose. The only thing I must have a physician in the state of Texas, and not every state, but in the state of Texas, is to delegate that prescriptive authority. So I can have an independent functional medicine practice without prescribing, and then they can, like, say I had a client and had a practice like that, the client could go to their primary care provider and get the medication that they need if we're having more of an integrative approach. But there's so many things you can do without prescription drugs. If there's people who, there's some medicines that I have to take my thyroid medicine or I can't function, and it requires a prescription. And so, but there are also options where you can have a physician that you know and trust who is functional medicine minded to be your collaborating physician. So I haven't decided yet which route I'm going to go with that, but there is definitely an option where you can be a certified functional medicine nurse practitioner and never have to write a prescription, and that's okay. But I'm a little early in the process yet to decide which track I'm going to take with that.
Do you know, I know you're early in the track for that. What does insurance look like that in that realm? Because I know a lot of people that I've talked to, before it was some people would want to do self-pay, some people would have insurance, some people have really good insurance, some people have decent insurance, and then they'll just self-pay with having insurance and kind of all in between. Now it seems that more people are trying to go the route of, I don't want to deal with insurance, I just want to pay out of pocket. Or you have the other, the spectrum is just getting more and more extreme. So what does insurance look like on that aspect? Like, does it cover it, or what's that?
So some insurances do and some don't. And so in the world where I live in the greater Houston area, it's really, really, really hard to find a functional medicine, an integrative medicine practitioner who accepts insurance. Most of them are self-pay, and they're expensive. I mean, it's, and I understand why. The patients, so there are a couple that actually will see patients, and what they're doing is they're billing the patients for the visit appropriately, as you would for the visit and the consultation. And then if there's any specialty labs, which a lot of the specialty labs insurance don't cover, or if there's compounded medication, insurance doesn't cover it. My compounded thyroid medication, my insurance won't pay for it. But when I was taking my one that it paid for, my hair fell out. So I'm like, I'm okay paying for my compound medicine because I don't want my hair falling out. So whatever. And so that's where patients are. So sometimes they have kind of like a mixture. I'm hoping, and it's really kind of a double-edged sword. Sometimes you wish insurance covered more, that as I've been a nurse practitioner for 17 years, unfortunately, the more insurance companies cover, the more they get their hand in it. And sadly, in traditional medicine, they're already dictating what we can and can't prescribe. No, I don't care that this particular antidepressant, after you change, remember, you change the person 3 times, you finally got them on something that works. You're excited, they're feeling great, they're functional again, they're playing with their kids, and then the insurance company says, oh no, I'm sorry, we don't cover that particular formulary. Well, I was the kind of provider that I would write about 6, 7 different letters arguing with the insurance company going, no, I already tried her on this one, I already tried her on that one, we finally got her, and you want to take her off and blah, blah, blah. We don't usually have time to do that, but I didn't care. And I like to write, that's my passion. So I would write the letters and argue with the insurance company to get it approved. Not everyone will do that. So my concern, my hesitation is if insurance does start covering some of this stuff, I'm afraid that they're also going to start dictating, just like now. If you have this insurance, you have to use this particular brand of medicine versus this one. Let's use insulin. This insurance policy covers only Novolog. This one only covers Humalog. We're talking insulin a lot of times, but if you're talking an antidepressant, that's huge. You might have somebody who said that we're only going to cover venlafaxine, but my patient didn't respond to venlafaxine, which is old Effexor's been generic for a long time. My patient responded to desvenlafaxine, and you won't cover that, but this is what I got her stable on. And so, it concerns me if, you try to find the best fit for your patients, but it really concerns me. I always tell my patients, I'm like, yeah, insurance don't cover it, but it makes me kind of nervous if they start covering it, because then they start meddling in it. And that's a reality. That's the reality of the world we live in, unfortunately.
Yeah. Well, this is a great conversation.
All right.
We definitely need to get on here again now that people are more aware of who you are. I mean, you really are truly a trailblazer in your industry. I mean, just the fact that you're writing insurance companies, how many physicians out there would sit down and say, let me do this? And there's a lot of great physicians, a lot of great nurse practitioners, a lot of great medical staff, but I really do look forward to seeing like where your next 5-10 years go, because I think it's just going to be amazing, and pushing the boundaries the way you are, and looking at things and how do I keep learning. I think that's probably one of the biggest aspects of we as a people can do, and I think you're going to lead that front very well. So thanks for coming on the podcast, and
absolutely.
really
Thank you
exciting.
for having me.
Yeah. Talk to you later.
All right.